So welcome everybody, Grand Rounds. It's really an honor and privilege to have Dr. Amin-Hanjani be our visiting professor today. She's really a well-recognized vascular expert. She went to undergrad, she went to boarding school in Scotland, and she went to undergrad at UMass Amherst. She then went to the much-wanted Harvard Medical School, where she was a classmate of Dr. Gawande. She then did her training program in one of the best neurosurgery training programs in the world at the Mass General. She was faculty there for a while, and then she went to the University of Illinois, where she, in a meteoric way, went up and became professor. She's now the program director there. Has done wonderful publications, involved NIH research, and has really emerged as a real leader in neurosurgery. She's been head of the vascular section. Is a very thoughtful scientist, a wonderful person to know, and we're very, very fortunate that she took the time to be with us here today. So without much further ado, Dr.
So thank you very much for that kind introduction. It's really a pleasure to be here. Of course, when I was telling folks that I had an invitation to come give grand rounds down here, and I mentioned it was in August, they said, well, why on earth are you going in August? So, although the cab driver last night did tell me that this is an unseasonably cool summer here in Louisiana, and I was thinking to myself, if 95 degrees is unseasonably cool, I hate to see what it's like when it's unseasonably warm down here. But it's a real pleasure to be here. What I thought I would do for this grand rounds, you know, it's always an issue when you go to give grand rounds. Should you give a topic that's more surgical and show videos, or should you talk about your research? What I thought I'd do, because I like to really focus on giving a talk that is perhaps helpful for residents, is to kind of go through a little bit of the arc of research that I've been involved with, which has really been clinical research. You know, when I was a resident, I did what all good residents did at the time, which was go into the lab and do research looking at strokes in mice. But it actually sparked my interest in the idea of cerebral blood flow. And that was something that then I was able to continue through clinical research. And the reason I was more interested in being involved in clinical research, because as a vascular subspecialist, as you know, the career got going, it became evident to me that to do really high-level bench work was going to be challenging. And it made more sense, at least in my practice environment, to focus the research towards what I was also doing clinically, and keep that similar interest that had developed in the laboratory of looking at blood flow, but using different tools and different diseases and applying it to the patients that I was seeing in my practice, that we were seeing in our institution, and using some of the resources at the institution that I had joined at the time, which was University of Illinois at Chicago. So I suspect you already know the answer to this question, because why would I be posing the question of does flow matter in cerebrovascular disease unless the answer I felt was going to be yes. But I think I'd like to spend the next 45 minutes or so convincing you why it's important and why we should be paying more attention to this when we're evaluating patients in our workup of patients with cerebrovascular disease, and how information about blood flow can really guide our management and improve our strategies for caring for patients. So here are my disclosures. The ones that are relevant is the GE Healthcare and Vassal are two companies that provide some material research support, not funds, towards the NIH study that we're doing that's looking at blood flow that I'll talk a little bit about. And I want to just off the bat acknowledge our group of folks at UIC. We have a virtual institute, the Illinois Stroke Institute, that includes a number of different subspecialties. And I want to particularly highlight my chairman, Fady Charbel. A lot of what I'm going to be going to discuss is based on looking at blood flow imaging with MR, a technique that he developed there at UIC and is now commercialized essentially. And our endovascular team, Vic Altish, the head of our endovascular division, and Ali Alaraj, who's our dual-trained neurosurgeon in our endovascular arena, as well as our whole cadre of other folks in the Stroke Institute. A lot of the work I'll be discussing, a lot of these people have really contributed to, and I'll acknowledge some other collaborators from outside institutions as we go through the talk as well. But basically, if we were to talk about measuring blood flow and doing it in a quantitative way, where might this be useful? And these are some of the different areas where, at least at our institution, we found utility in blood flow measurement when evaluating cerebrovascular diseases. Obviously, cerebrovascular occlusive disease, if you have a stenosis or occlusion of blood vessel, how's that going to impact on blood flow to the brain? Turns out to be quite useful for managing complex aneurysms, AVMs and AV fistulas. We talked a little bit with the residents about that, reviewing an AVM case earlier today that's on the service. Situations where patients are presenting with venous sinus thrombosis and you're interested in the venous blood flow. And certainly, obviously, naturally, you would think vasospasm, a condition which affects blood flow to the brain. It would take me longer than an hour to cover all these entities. So what I'm going to really focus on for this talk is the idea of blood flow in cerebrovascular occlusive disease. And I think we're all very familiar with the classic classification of how ischemic strokes occur. And what we're really talking about in the setting of ischemic stroke would be cerebrovascular disease that's large vessel, basically atherosclerotic disease. Carotid stenosis, intracranial stenosis, vertebral disease. These are disease processes that we as surgeons often are involved with, or interventionalists, as opposed to the other cadre of stroke etiologies that fall traditionally more into the medical realm of management. Now, when we think about large vessel disease, certainly one of the major etiologies of stroke is still a thromboembolic one that does not require necessarily a surgical intervention. But the other component of this is the idea that if you have a compromise of the lumen of a large vessel, that may lead to a hemodynamic compromise that predisposes to stroke. And I think the current thinking is that even in conditions where thromboembolism plays a role, if there's a component of flow compromise, the two together synergize and create a much worse situation as far as risk of ischemia. And why does this matter? Well, you could imagine that if some disease process is more thromboembolic versus more a result of hemodynamics, the type of treatment that you would offer, whether it's something to open the vessel or something to just deal with thromboembolism, like medical therapy, would be significantly affected by the mechanism that's causing the stroke in that setting. So let's just talk about carotid stenosis. I mean, this disease, although it causes a progressive occlusion of a blood vessel, is really the quintessential thromboembolic pathophysiology. Back from the days when C. Miller Fisher, the neurologist at MGH, kind of first described seeing embolic phenomenon in the retina and emboli to the brain from this condition, pretty much you could say, oh, the book is closed on this disease. This is a thromboembolic problem. It's not hemodynamic, even though it's a large vessel occlusive process. But if you look at some of the large study data on carotid disease, specifically the NASCET study, which is probably one of the most quoted studies in carotid disease, that demonstrated that surgery was better than medical therapy for symptomatic carotid stenosis, greater than 70% certainly, and also greater than 50%. If you look at that data a little more carefully, you might start to ask, well, if it's just a thromboembolic problem, why does 90% stenosis have a higher stroke risk than a 70% stenosis, which has a higher stroke that's in the 50% stenosis? Is it just that the plaque gets more friable as the stenosis gets greater? Or could that be a marker of hemodynamics, meaning that once your stenosis is greater, your hemodynamics are worsening? So that would be kind of one interpretation of why your stroke risk increases. And in fact, if you look at curves of what happens to blood flow, guess where you start to really see the drop-off? Right about 70%. So that's kind of too much of a coincidence in some ways, is that that's when we see stroke risk go up in carotid disease, is also the kind of the point where you expect to see blood flow go down. And interestingly, this is why blood flow is a more reliable marker of what's going on in large vessels than velocity, for example. So velocity is what TCDs and ultrasound can measure, and a lot of people rely on that. But in fact, velocity has an unusual relationship to stenosis, meaning it goes up before it goes down, whereas flow, once it starts going down, will continue that way. So a lot of what I'm going to focus on is the idea that we should really rely on blood flow measurement rather than a surrogate measurement like velocity, which is what most people are doing because it's easy to do. TCDs and ultrasound are easy to do, but perhaps aren't giving us as useful information as blood flow is. So you could have a hemodynamic problem within a vessel if you have carotid stenosis, but you could also be interested to say, well, does that matter as much as the flow distally in the brain itself? Because a flow that's low in the carotid may not have a impact on the intracranial flow, primarily because of the unique system within the brain that allows compensation. And what is that compensation? Well, it's through the circle of Willis, and it's also through, to a great degree, leptomeningeal collaterals. These are collaterals that have been given less kind of attention, so to speak, over the years, but are incredibly important. There was a beautiful study done by a neurosurgeon, actually, Bart van der Zwaan in Utrecht, looking at just these collaterals and visually identifying them in cadavers, where really on the peel surface you have incredible connections between peel vasculature, and those peel connections can allow you to compensate for low flow in a large artery by having territory filled in blood supply-wise from another blood vessel. So those collaterals can compensate for low flow in a proximal vessel. And in fact, if you look again back at the NASCET trial, it turns out that even though high-grade ICA stenosis shows a high risk of recurrent stroke, it's much higher if you don't have collaterals than it is if you do have collaterals. Again, the implication being here that hemodynamics matter in carotid disease, even though we think carotid disease is primarily a thromboembolic problem. So blood flow still matters, even in a disease process that is, seems to be primarily thromboembolic. Now, if we believe that flow matters, the next question becomes, can you actually measure the flow? Can you measure it in the vessel of interest? And can you measure it in the brain? And the technology that we've used for several years now to do that, very simply, essentially, is quantitative MRA. And this is a technique, basically, that uses phase contrast MR. It's not some special, unusual technique of imaging. It's phase contrast MR imaging. And it just has software that allows it to be done quickly and efficiently and accurately using a combination of time of flight and phase contrast. So just to go through that very briefly, basically what it entails is doing a simple time of flight MR, which is routine on every MRA study, using that information to create a 3D surface rendering. That surface rendering is used to locate places where blood flow measurements can be performed perpendicular to the axis of the blood vessel, because that's important for the accuracy of the flow measurement. And then the phase contrast MR is what actually gives you a flow measurement in that vessel of interest. And you know, when I talk about quantitative MR, always the first question from skeptics and radiologists and neurosurgeons is, well, you know, who's to say this is accurate data you're getting? Turns out there's been a lot of validation done in vitro, and we ourselves at UIC looked to do an in vivo study because people were often unsatisfied with the idea of just having in vitro validation, and did basically a carotid stenosis model in a canine and used simultaneous flow measurements using a transonic flow probe, which is pretty much considered the gold standard for flow measurement in vivo, versus and this was MR compatible device, with the animal inside the MR magnet creating different degrees of stenosis, different flow rates, and comparing how well the QMR measurement compared to this, and found that it's a really tight correlation. These are the waveforms you got with each of those devices and the correlation you see with that, and that the proportional difference, which is a marker of how well it performs compared to that gold standard, was generally within 10%, which is considered really a very good marker of accuracy with a new technology, and was within that range across a range of flow rates. So even at high flow rates it performed the best, but even at very low flow rates of about 20 cc's a minute, the accuracy was within 10%. So it seems to us to be certainly valid and accurate within the range of importance for clinical use. So the question about whether you can measure flow in a carotid stenosis, well, this is the QMR on this patient who has a very tight stenosis. Then you might say, well, it's so tight, obviously the flow is low. Why do I need to measure it? Well, I would say you can measure it in that carotid, and sure enough, it's slow. It's only 82 compared to the other side, which is 220. But in some ways, even more importantly, you can see if that flow decrement is having an impact intracranially. And in this case, it's not. because this patient has good collaterals. They have a good PCOM that's maintaining blood flow intracranially. And so that could be information that may be useful in determining if a particular patient might need treatment or not, particularly an asymptomatic patient where there's some controversy as to whether asymptomatic disease warrants intervention currently, and with trials planned to re-examine that issue. What you can do with that information also is confirm some of the things we suspect. This is a study we did with one of my colleagues, Zogo Gawala, up in Boston, who Anil knows well as well. He's been very interested in carotid disease and flow. And we looked at the relationship between flow and degree of ICA stenosis, and basically we're able to show nicely that this part of the curve where flow tends to drop does actually happen in real life. That, sure enough, is what goes on. As your stenosis gets higher, if you're at 70% or more, the flow starts to decline. And more recently, we studied about 45 patients who had QMRs, and right at 70% is when flow starts to go down. Between 50 and 70%, flow doesn't really alter. So 70% truly is probably a marker for when a hemodynamic change can happen. Now, beyond just measuring the flow, the next question really is, well, how do we interpret that? You know, and really, what's normal, what's low? How are you going to know if someone's impaired or not if you don't know what normal is? And that leads to a larger study we performed over the course of several years, basically looking at healthy volunteers. And during this time frame, we're able to recruit 325 healthy volunteers across this age range. It's challenging to find 80-year-old healthy volunteers, let me tell you, because we wanted people without a history of basically hypertension or stroke or other disease processes that may affect their quote-unquote normal flows. But we were able to get a good sampling within all the age ranges, and ultimately we split them into 3 groups, and I'll show you one of the reasons why we did that in a moment. But what we did in this study was measure every major blood vessel intracranially that would be of interest, the MCA, the ICA, the ACA, et cetera, and then look at their numbers in relationship to various factors that might affect it. And as you probably would expect and has been described before, blood flow declines with age. The presumptive reason for that is that you have less tissue that needs to be supplied with age, and therefore your blood flow goes down. Similarly, if someone's had a big stroke, their blood flow comes down because they don't have as much tissue to supply. So the assumption there is that there's less blood flow due to atrophy, cortical atrophy, etc. And that rate of decline is about 2.6 cc's per minute per year. And so you can see that there's a fair difference of normal flow between the youngest and oldest decades. So it would be important to factor that in if you were evaluating someone as to whether their flow is normal or not. And we found that there really wasn't an effect of blood pressure, race, or gender if you were adjusting for this thing, which was the main predictor of blood flow. The other interesting thing to look at, which one might not consider and would really potentially have an impact on what normal flow is that these proximal vessels in the circle of Willis, the basilar, the carotid, really can be subject to a number of anatomic variants. So if you have a fetal PCA, your basilar doesn't need to carry the blood flow for the PCA. Does that mean that the basilar flow would be different in someone with fetal PCAs than not, even normally? Or if they didn't have a PCOM, or if they had a hypoplastic A1. And it turns out that that is very important. For example, in the basilar, the average flow across the whole cohort was about 140 cc's a minute. Now, do you think the patients with fetal PCAs had lower or higher basilar flow? I'll ask any of the residents too. So fetal PCAs, you think their basilars would be lower or higher? Lower. So sure enough, quite a bit lower. I mean, dramatically so. So you could have a patient who only has 80 cc's of flow in their basilar, and yet it's perfectly normal for them if they have fetal PCAs, as opposed to the patients that don't. So there's a big difference in those. And similarly in the carotids, there was a significant difference depending on the anatomy. And similarly, because of A1s, there's a significant difference in ICA normal flows. The other kinds of things that we discovered based on this is if you really want to interpret what's normal, because of these two variables that seem to impact the flow significantly, you're better off to look at terminal vessels because they're not going to be impacted by the anatomic variance. And to try and adjust for the age issue, if you can index your blood flow of a vessel to the entire CBF, that CBF will have gone down proportionally, and that index should adjust for age, basically. So those would be the two strategies to try and get better ranges of normal flow with which to compare. So for example, if we look at the flow in the MCAs, which is a terminal vessel, versus the basilar, which can be affected by anatomic variance, the variation, which you can kind of give a numeric value to by looking at the coefficient of variation, just a statistical marker of the variation, is much higher in the basilar. And that's what we now expect based on the fact that the basilar is affected by anatomic variance. And similarly, if you index the flow, you get rid of the variability that's related to age, and your coefficient of variation goes down even further. So we're still working with this data to figure out what's the best way to apply this to disease states. So, you know, if someone's MCA is one standard deviation below, is that a marker that they're at low flow? And that will need prospective validation, but this is really the first step in that kind of work, is to figure out what's normal, what's low, and what's the implication of that. So if we have some idea about that now, the next real issue, well, does this really have any clinical significance? So let's go back to carotid disease, where I'm trying to make a case that there's some importance for this blood flow. I mean, is there any hint that blood flow is going to affect stroke risk? Could it be that if an asymptomatic 70% stenosis arrives on your doorstep, if their flow is okay, you should leave them alone? If their flow isn't, you should do surgery? Is there any hint that that would be useful? Well, right now we don't know the answer to that. We'd have to do a prospective study to look at that, but there is some hint about it. So in our small cohort of about 45 patients, what we found is that if you looked at patients that were symptomatic or asymptomatic, compared them as far as how their blood flow was affected in their carotid, both groups had a similar effect on their blood flow if we looked at the ratio of their normal to abnormal blood vessels. So most of them had about a 50% drop in blood flow in the affected carotid. And that's because in our practice we tend to see high-grade stenoses. These are mostly greater than 70% stenosis. We know that greater than 70% tends to affect your blood flow. So sure enough, most of these folks had a ratio of abnormal to normal of 0.5 in their blood flows. What's more interesting, though, is if you compare the patients that were asymptomatic to symptomatic as far as their intracranial blood flow, that's where you start to see a difference, because the patients who were symptomatic tended to have a worse blood flow in their distal territory, in their MCA. So this is just correlative, but the correlation here would be that maybe symptomatic patients are more likely to be so because their flow distally is affected. It's not the only etiology, because plaque stability and thromboemboli matter, but blood flow may be another important element in this. So possibly distal flow impairment could be a marker of stroke risk, something that's worth investigating in the future. And the other area that looks to be very interesting is the idea of if blood flow, again, intracranially could affect cognitive function. There is a lot of existing small group data, small studies published that really suggest if your blood flow is reduced in the setting of carotid disease, you're at more risk for cognitive impairment. And the natural kind of follow through with that would be that, well, if you could fix the carotid stenosis, fix the blood flow, can you improve the cognitive impairment? I mean, vascular dementia is a major, major issue. And the topic we're going to discuss tonight, the paper that you gave us kind of hints on that too. So the idea that, you know, if there's a subgroup of dementia that's reversible by improving blood flow, that would be very exciting. So is there any data to support that? Well, this is another study we did with Zogo Gowala, my colleague up at the Lady Clinic, looking at patients who had undergone carotid revascularization, stenting or endarterectomy. looking at their cognitive function pre and post treatment. And again, what was really fascinating here is that the patients who had pre-op flow impairment and improved their blood flow in their MCA, again, their intracranial vessel, were much more likely to improve cognitively. So again, the idea that if you improve blood flow intracranially, you can actually see a reversal or improvement in cognitive function is kind of an exciting idea that deserves, I think, future and further study. And this is one of the areas we're looking to get further patients and recruitment to look at this. Now, are there other disease processes where this could be important? Well, one area that I've been particularly interested in for the last several years is vertebrovascular disease, because this is kind of the redheaded stepchild of atherosclerosis disease. Everybody focuses on the anterior circulation, the carotid. There's been very little work done on vertebrovascular disease. But it's a really important etiology of ischemic stroke, especially because even small strokes in the posterior circulation can have very devastating impacts. You're affecting the brainstem, very eloquent territory. And because everyone's focused on the anterior circulation, there's a lot of different techniques for assessing hemodynamics in the anterior circulation. PET, xenon CT SPECT, TCD, MR perfusion, CT perfusion. It turns out these techniques don't work very well when you want to look at the posterior circulation for a number of reasons that relate to the imaging resolution of the brain stem. You're looking at a much more compact territory. There's artifacts that affect how well you can visualize the posterior circulation tissue. So the idea here would be that if you can't image the flow at the tissue level, if you could image it at the large vessel level with quantitative MR, that would be a surrogate marker of hemodynamics in the tissue level. And it would allow you to measure flow in the affected vessel and in the distal territory. So for example, if you're worried about someone's posterior circulation, you could easily measure the inflow, which would be the flow through the vertebrals or the PCOMs. And you could measure the territory that's actually at risk, which is supplied by the basilar or the PCAs, and compare that to what would be, again, normative ranges, which we've started to develop based on looking at healthy volunteers. And this idea caused us to take a look back a few years ago at a group of patients who'd had quantitative MR done and had vertebrovascular disease, and use those kind of flow numbers to stratify them as normal or low flow on a very simple algorithm, which I'll show here. And this is really quite simplistic in concept. The idea being that you would do your flow measurement, you would look at someone's basilar flow. If it was normal, you'd stratify them as normal flow. If that flow was not so good, then you would look at the PCA flow, because that would be the distal territory. And if that also was low, then you would stratify them as low flow. If it wasn't, they would be stratified as normal flow. So it was kind of an empiric stratification of flow based on these QMR measurements. And this is an example of a patient who had basilar long segment stenosis, had very low flow in the basilar, but very good flow in the PCAs because of a large PCOM. And for the purposes of this algorithm, they'd be characterized as normal flow. Whereas this patient who did not have such good collaterals and had low PCA flow would be characterized as low flow. And we did this stratification and then looked to see retrospectively if it was at all predictive of stroke risk. And sure enough, it was. I mean, this was a very small study, but it was intriguing that the patients that stratified as normal flow, none of them went on to have recurrent strokes as long as they were on medical therapy. Whereas the patients who were low flow did go on to have further strokes. And even more intriguing, the ones that then went on to have intervention seemed to have a better natural history a little bit than the ones that did not. So this set up the notion that perhaps their flow status really would predict who's at high risk and who would warrant intervention. Because intervention for basilar stenosis is not trivial. There's risks that come with it, for example. And ultimately, the conclusion of this study that flow was a predictor of stroke risk. But the problem is that despite wanting to make this a definitive conclusion, this is very preliminary because it's a small retrospective study. And really what would be needed is a prospective observational study where we evaluate all the confounders and see if this observation is real. And that's been the study that started about 6 years ago now, that we were lucky enough to get some funding for, to look prospectively at patients with intracranial and extracranial vertebrovascular disease, measure their blood flow, and then just follow them. It wasn't an interventional trial, just an observational study. And our protocol was for everybody to undergo quantitative MR, and we were doing perfusion imaging to see if we could find any way to measure the perfusion in the posterior circulation, and look to see if these symptomatic patients on medical therapy, if their flow status really predicts stroke risk. And we recruited sites across the US. We recruited Toronto so we could call it an international study. We've got a Canadian site, so it's an international multi-site study. And it's a small study, but let me tell you, getting 80 patients into a study, it's a task. It's a task. So any major trial that you see or you're involved with, recruitment is always the toughest and most important element. But we were lucky enough to be able to recruit, but we needed an extra year to do it. Our original plan had been to do it in 4 years. Ultimately, we went an extra 5th year. And now we've just as of July 1st finished all the follow-up for those patients. And so I don't have results to share with you other than we've started to look at some of our baseline cohort, what their flows were, just to start seeing associations of how many low flow and normal flow patients we had. So I'll be curious to see who can identify these. It'll be like a prize for whoever can tell me. This one should be more obvious. That's Niagara, right?
Angel Fall.
Angel Fall. I too. That's right. If there's anyone that would know it, I thought you would. So yeah. So do they have low flow or normal flow? So what we found, just looking preliminarily on the baseline cohort, not the observational period, is that sure enough, basilar flow and basilar stenosis correlate very well. Vertebral flow and vertebral stenosis correlate well. Again, these are all patients with 50% or more, and most of them have 70% or more stenosis, so we're seeing that nice correlation of flows. And we're seeing things that you kind of would expect, but nobody's really measured before, which is that if you have tandem stenosis, meaning you have stenosis in your vertebral and basilar, your flow is significantly lower than if you just have stenosis in your vertebral or your basilar. So something others have described in other settings, but has not really been quantitated before, that there's a synergistic effect of the tandem stenosis in reducing blood flow. And tandem disease is basically the worst problem you can have as far as hemodynamics. Now, based on applying our flow algorithm, only about a quarter of the patients fell into what we call this low flow status. So these are all patients, if you looked at them anatomically, they all look bad. They've all got high-grade stenosis. And yet, if you look at their distal flows, only about a quarter of them are really meeting our criteria for what we would consider hemodynamically impaired in their distal vasculature. And what's interesting about that is that doesn't correlate with tandem disease. And our thought is, of course, that that's because your distal flow status is more dependent on your collaterals, nothing to do with your proximal disease. And that seems to bear out. There's really no connection between where your disease is and your flow status, because that has more to do with how good your collaterals are. And so the distal flow is something that's independent of tandem disease, and we think is the more important variable to look at. So we don't have the final data on whether it actually predicts stroke risk, but the preliminary review at least shows us that flow behaves as expected in those affected vessels, because it correlates with stenosis and diameter, and tandem disease affects it. But if you look at distal flow, that is not predicted by location and severity of disease. And this is what we traditionally do in clinical practice, is we look at how bad the disease in the vessel looks. We've been paying no attention to what happens to the flow distally. And maybe it's time that we start looking at the flow distally as the more important variable, because that's really what reflects collateral flow. And we think, although we don't yet know, that this may help us identify high-risk patients. Maybe we'll be wrong. Maybe my next talk will be, flow does not matter. But at this point, we think it's important. Now, is there other disease processes that this could affect? The other disease that's become, I think, more and more recognized as a major stroke etiology could in fact be the greatest etiology of stroke worldwide, because it's so prevalent in Asia and China, is intracranial atherosclerotic disease. And as I said, in the US it's 8 to 10%, but worldwide it could be a much, much greater proportion of ischemic stroke etiology. And the question for intracranial disease is similar. You know, should we be looking at hemodynamics? Should we ask the question not just how tight is a stenosis, but is it flow limiting? So here's an MCA stenosis that looks pretty darn tight, but you measure the flow, and that's a very much normal MCA flow. Now, would that patient be the same as this patient who also has MCA stenosis, but has a marked reduction in their blood flow? My guess is no, they're not the same, that the one that's flow compromised is at higher risk. And beyond that, should we just look at the flow in the vessel, or should we look to see if there's collateral flow? Because maybe if the MCA even occludes, how many times have we seen an MCA that's a patient who's completely asymptomatic, hasn't ever had a stroke, but has an incidental MCA occlusion on their imaging? Well, how did that happen? Well, they obviously had regional flow through compensatory collaterals that help prevent a stroke. So you can actually even measure that using simple volumetric large vessel flow measurements. So here's a way to do it. You look at the ACA and the PCA flow, because those are the ones providing the collateral. And so for this patient, their MCA flow is very low, but look at what's happening to their ACA flow. It's double what it is on the other side. And their PCA flow is significantly elevated because these vessels are giving peel collaterals, and we can measure how much. And we can pretty much, if you do the math, they're pretty much completely compensated, same as the other hemisphere, because of the increase in flow in their compensatory vessels. And again, the idea being that this is probably important. It's probably going to differentiate who's at high risk or low risk of stroke. And unfortunately, intracranial disease has a high recurrent stroke risk. That's despite medical therapy. Bypass for intracranial stenosis has never really proven to be a particularly good strategy, unfortunately. Unfortunately, especially because that's one of my favorite operations is bypass. And endovascular treatment has stroke risk. In fact, the trial that examined endovascular treatment, SAMPRIS, which you probably all heard of, was halted early because the event rates in the treatment arm were so high, even in the immediate period, the 30 days. So we don't really have a low-risk treatment for this disease yet. So if you're going to treat someone, you're going to really want to treat the highest risk patients, the ones that you can help the most, because your treatment has risks as well. And the question going forward will be, maybe SAMPRIS just chose everybody that was over 70% stenosis. Maybe the better strategy going forward will be to choose the people that are actually hemodynamically impaired as perhaps the more appropriate group for that. And if we're going to do that, we're going to have to start thinking about whether we should be looking to see how effective our treatments are. If flow is potentially a problem to start with, is our treatment actually helping flow? And to actually measure when we do an intervention whether the hemodynamics improve. So we've done this now. We don't do a lot of intracranial stenting, just for the reasons I described, but for the few patients we've done over the years, we've measured their blood flows pre and post stenting. And you do see a nice relationship or improvement in blood flow on average that's about twofold after you stent an intracranial vessel. But I want to draw attention to this, which actually shows you the individual patients. Not every patient gets that same improvement. Some people are stable, and that's probably because their flow wasn't that impaired to start with. Maybe that patient should never have been stented, even though their stenosis looked severe. So I think this is the kind of individual patient data that will be important in selecting patients in the future for whether they should have a potentially high-risk intervention. So here's just an example of a 49-year-old with a tight stenosis. You improve the stenosis, not back to normal, but a fair bit, and you get a marked improvement in blood flow doing that. And in addition to that, you don't always just see improvement in the vessel of interest. Generally, you can see a major change in the vessels that are distal to that territory. So here's another patient who was in pretty significant trouble. She pretty much had a left ICA occlusion, a tight right ICA stenosis, flow that's impaired in that stenotic vessel. Here's her blood flows. I mean, incredibly low in both MCAs. She's got an occlusion on this side, subtotal, very low flow. And we can see that all the distal vessels are pretty significantly impacted by this proximal stenosis. So she undergoes a stenting. It's not perfect result, still a residual stenosis. Improved flow in the ICA, but even more dramatically, look how much the flow is improved in all the distal vessels. And to the degree where she now has so much improved cross flow that her contralateral MCA has improved almost close to normal again. So you can impact the hemodynamics even in the other hemisphere pretty significantly. And we use this kind of data in our decision making. This is a patient where you might have said, well, this side's occluded, we should offer her bypass. She's symptomatic. Bypass can still be effective in patients who failed medical therapy, even though it hasn't been proven as a first-line treatment. But in fact, treating her stenotic side essentially treated the left hemisphere also, meaning she didn't require a bypass on that side. You can actually measure the impact of bypass as well pretty easily with doing flow measurements. So here's a patient who's not a candidate for any kind of endovascular treatment, has an MCA occlusion, doesn't have a huge stroke because they do have some compensatory collaterals, but is kind of teetering on the edge, is having frequent TIAs, frequent TIAs, frequent TIAs. And this is the kind of patient we still offer bypass for. And so I've done a double barrel STA bypass for this patient. And the question is, well, the angiogram looks good, but how much flow did we actually improve to this person's brain? And we can measure it directly. Measure each of the bypass branches and say, boy, we got him about 80 or 90 cc's extra flow into that hemisphere, and monitor that over time to see if it changes, improves, gets worse, depending on how the bypass is functioning over time. And that's another really important component of flow measurements, I think, is to be able to monitor the effect of our treatment and then follow it over time. And do it non-invasively. Instead of having to do an angiogram to look at that bypass, we can actually measure the flow. Or in the case of endovascular treatment, in-stent stenosis or restenosis is a major problem. And it's something that you can pick up with blood flow measurements very easily. It's hard to image these patients with MRA or CTA because the stents will create artifacts, but that doesn't affect the flow measurement. So you could actually monitor a patient with blood flow measurements, and as long as their blood flows are okay, you know that they don't have a significant restenosis. You don't have to angio them repeatedly to know that information. Now, it's easy to do that in extracranial vessels because you can measure the blood flow far away from the stent where there might be artifact. It's harder to do it intracranially, and in fact, is it even feasible to do it intracranially? So again, on the patients that we have stented, although again, we do it rarely, so it's not a large group, we've looked at this issue, and you can measure intracranially the blood flow distal to the stent where the artifact is. And in this small cohort, what was very, very clear is that patients who had stenosis, restenosis that is, their blood flows predicted it every single time. If their blood flow dropped more than 25%, that was 100% sensitive and specific. And in this obviously very small group. And even more interestingly, if their blood flow had dropped a lot, those are the patients that became symptomatic from their restenosis. So here's an example again of a patient with a very tight stenosis, low flow relatively in that carotid, gets stented, has much better flow. At 4 months, really tight restenosis, and the flow has dropped dramatically. So if you were following flows, you would know that there's something going on right here. And that's pretty much what we do now. We just follow the flows, and if the flows show a dip, that's when we do an angiogram. And sure enough, unfortunately, while we were entertaining what to do about this, what's our next step, should they try to replasty, 2 weeks later she has a stroke, and her flows have gone down even worse. So it becomes a technique that can help you pick up a problem, hopefully before it becomes symptomatic, and that if it has come to the point where the blood flow is really dropped by 50%, that's probably a patient who's at risk and that you should intervene upon rather than just to keep waiting and doing medical therapy. So in conclusion, hopefully I've been able to convince you that at least in cerebrovascular occlusive disease, that these flow assessments, you know, can be useful. They can help us diagnose the situation as far as the hemodynamics of a particular patient. I haven't proven it yet, but we think this will be helpful in identifying high-risk populations that may really be the ones that we should focus on for interventions in the future. And certainly if we do a treatment, it's a very easy, non-invasive way to monitor how effective that treatment was as far as improving blood flow. If we're doing an intervention to improve blood flow, we should be able to demonstrate that quantitative with blood flow measurements. And then ultimately for being able to follow those patients long-term to see if our intervention is durable and whether the efficacy of it is going to be long-term or not. So I think I'll stop there, and I'd be happy to entertain any questions.
Yeah, my question is, how much does this cost? And is it easy to put in? I mean, like if you're buying a new MRI, do you need a special MRI?
No, I mean, that's the nice thing about it. It's really literally a software, so it can be used on any any of the three major vendors, Siemens, Philips, GE. In fact, that's one thing that was important for us when we were setting up the multi-site study, because each site had a different manufacturer MR, and it can be done 1.5 or 3T. On 3T, you get usually nicer images of the vessels, so I would say 3T is a bit superior in that regard, but at least our validation studies don't show a difference in the flow measurement itself. The software itself, the company that was marketing it had a little bit of a wacky marketing strategy, I think, early on, where they were putting it in for free and then charging per scan. And then I think they realized that most places didn't like that because they have a capital budget. Right. So you either buy it or not. So I don't know what they're charging for the software, but it's whatever, $1,000. And then once you have it, you're able to use it on your scanner. And it does require a bit of buy-in from radiology to make sure that the parameters are set up, and you know, they come and install a computer and stuff like that. So for us, in terms of doing studies, it's been really nice, because once something is commercial, then usually there's, you know, it's easy to disseminate and have it be standard. Anything you use that's just research-based, unfortunately, it's hard to standardize institution to institution, but because their software is a commercial one, is pretty standardized, we've been able to implement it at multiple sites, you know, pretty, I should say, easily, in the sense that the quality of the studies then is, you're getting the same thing. This can be done on any machine by a radiologist who knows the right sequences. It's just hard to do if you don't have the software. It's time intensive, right? They'd have to plan where they're putting the cuts and do a rendering and all of that. So the software isn't anything magical. It just allows it to be done easily, and so that you can do it routinely. And we use it for clinical use routinely as well for that reason.
Any questions?
In this population of patients, what's the relationship between the systemic blood pressure and your measurement of flow?
Yeah, that's a great question. So in our healthy volunteers, there was not a relationship, but I think that's because the healthy volunteers have relatively normal blood vessels, and they have a blood pressure within the range of autoregulation. But I can tell you, we've seen in other situations of patients who are vasculopaths or hypertensive, where their antihypertensive regimen will affect the blood flow. You know, so they're not in the autoregulation curve the same place, and so if their blood pressure is pushed or lowered, it doesn't affect their intracranial flow.
As I see, every day I see problems with the blood pressure because they follow the guidelines, less than 120/80.
Yeah.
And then the majority of them end up with the watershed stroke or other kind of problems, and
Right.
it's related to the increased brain perfusion pressure.
Right. No, I mean, we've seen that, and we've seen certain antihypertensives have more of an impact. Beta blockers, for whatever reason, seem to reduce it further. And it's this dilemma of you want to treat the hypertension, but if you lower too much, then you can be at risk.
You affect the collateral circulation when you lower it too much.
Yeah.
Right.
Have you used this in unruptured aneurysms or unruptured AVMs to get a sense of if it'd be valuable to predict which of those may rupture?
We haven't looked at it for that purpose in ruptured aneurysms, but we have in AVMs actually. And what was interesting, I was discussing with the residents earlier, what we found that, so AVMs are more challenging because you have to figure out what blood flow to measure, but ultimately we've either measured a primary draining vein or the primary feeders. And what was kind of fascinating about that data, Ali Alaraj, one of my colleagues, is kind of the lead on that, and what he had found when he analyzed that data was that the blood flow to every AVM we looked at, if you looked at it based on volume, I mean flow per cc of AVM, so he measured the AVMs, was uniform, which really surprised me, because I would have thought an AVM could be high flow, low flow, quote unquote, and they are high flow and low flow, but if you adjust for their volume, they're all within a very small standard deviation of each other, and it did not correlate with hemorrhage risk. I mean, we were looking at it retrospectively, ones that had hemorrhage versus ones that hadn't. At least they didn't seem to have a different, flow, because they were all so similar, and the things that mattered more seemed to be venous side things. So I think AVMs are more a pressure problem than a flow problem. I mean, that's my interpretation so far. So I don't think it'll be useful. The way we found it useful, though, is for when we embolize AVMs to measure. We've been doing that now, where after embo sessions, we measure their flows to see how much it impacts. Because right now, I think the standard is people embolize an AVM until they kind of think it looks ready, and then we remove it surgically, right? There's no, it's kind of very subjective. So we started looking at to see if could you do it more objectively, so that you actually stop embolizing when the flow drops, rather than you just stop embolizing because you've done 2 or 3 sessions. And it's been fascinating, because sometimes for some large AVMs where they do multiple embos, the first couple of embos do nothing to the flow. And I think it's because when they shut off one channel, it redirects, and then suddenly the third embo, it'll drop, and they'll have done a 4th and 5th embo, and it's like probably didn't make a difference beyond that. So I think that's where it might turn out to be valuable in AVMs, is helping to guide how much one should embo, and if you're doing it pre-surgically, and you know, when you should stop emboing for large, difficult AVMs.
Looking at different levels of flow and like a rat and just something simple like the water maze or something, or even like collaborating with somebody, it seems like it'd be pretty straightforward.
It would be feasible, actually. It could be. Yeah. Yeah.
So, you know, because there's some things that you can't control, you know, you don't really want to compare stroke to humans, because the motor aspect is going to interfere with the cognitive testing. So that might be a good, if you're looking for a way to augment some correlative data in humans, that would be a good way to go, is just do it. There are a lot of cognitive memory and learning. The water maze test is a classic one that I think is still pretty accepted, and look at different levels of flow and see if we can get a good R-squared with that type of analysis. And then, so you've convinced me that flow matters, but why, particularly in anterior circulation? Do you think that flow is related to thromboembolic disease? And if you have low flow, you are somehow predisposing the cells to crump faster if they get an embolic event.
Right, right. I think there's very much, I think that's very likely, meaning that I think there are conditions that are embolic where there's probably emboli going and they're getting washed out if you have great flow. And if you've got kind of stagnant flow, they'll get caught in there. The simplistic version of that. So I do think that a lot of the diseases where thromboembolism is clearly important, because sure, their stroke risk goes down when you put them on aspirin and Plavix and all of that. It's yet kind of an additional synergistic additive factor that's going to bump them to yet another level of being at risk, because they don't have the washout, basically, you know, effect of that.
I will say during Christmas, our colleagues have a big ad out on I-49. It says flow matters. The only problem is they're urologists. So on behalf of the, I should get you that. On behalf of the department, I'll black for you. Thank you so much.